Okay, sorry. My name's Angie. I'm a healthcare facilitator with the the Community Networks of Specialized Care. Same team as Scott. And my background is advanced practice nursing. I'm a healthcare facilitator.
Hi everyone, my name is Aamir. I'm a behavior facilitator with the same team as Angie and Scott, the Community Network of Specialized Care. My role is behavior facilitator, as I said. I work collaboratively with the entire team. And I guess you'll find out a little bit more about my role when I speak a little bit later into the presentation.
So, we're going to talk a bit about developmental disabilities in the context of healthcare disparities, the tremendous progress that's been made over the past couple decades, and how it overlaps a lot with complex behaviors, and how it makes a major barrier actually to accessing healthcare. So bringing about an awareness of the healthcare disparities, looking at how challenging behavior can impact on access to healthcare, and an awareness about supportive approaches and some resources. This is sadly taken from the ministry website, actually. Like it's the history of developmental disabilities and institutions. So there are lots of photos online that show what the Ontario institutions look like, and the conditions there. It's a major part of historical context that's actually not so historical, because the remaining 3 institutions closed just in the past decade, by 2009. So I know I was nursing at that time, and not part of the resource of knowledge that was in the institutions, because that's where people lived. So their health care was also there. And with that, now we're transitioning to inclusiveness and how to provide health care in the community for people with developmental disabilities. And there was a facilities initiative, a lot of research done that showed that people are doing a lot better. I have very visual examples, because I saw some of the people who transitioned out of the institutions in 2007, 2008, and they were living in locked kind of conditions. And I met a person who was sitting on the porch, enjoying being, in the community. So people are doing a lot better, and there's a lot of research to show that. But on the other side of things, that knowledge for healthcare that was a specialty in the institutions now also needs to transfer to our community, and to healthcare providers and everyone who supports people with developmental disabilities. So I really feel like I'm going to harp on H-Card a lot. Have people heard about H-Card? Healthcare Access Research and Developmental Disabilities?
I have a quick question.
Okay, yeah, sure.
I don't think we have your PowerPoint
Yes.
package.
Yeah, that's true. So, yeah, at the end of this, we have our emails, and also I think it's definitely helpful for us to send the PowerPoint, but I think if a major takeaway today is the behavior sort of information, as well as the H-Card website. So a lot of the content is actually on the H-Card. It's taken straight from the H-Card website. But we will provide the slides.
And if you send me an email, again, my email is at the bottom of the agenda. Send me an email and I will send you whatever. Okay?
Thank you for pointing that out. So H-Card is really important in the sense that it's the evidence that we practice from in terms of healthcare and how people with developmental disabilities are doing with healthcare. It's taken from a sample of over 65,000 people in Ontario, so it's Ontario-specific research. And it looks at the various health outcomes, and I'll show you some information on the slides about that. But it also goes into a lot of detail about why people with developmental disabilities are facing a lot of issues in accessing healthcare. So fresh off the press, 2019, there's an updated version of health card information that's going out. It's called Addressing Gaps in the Healthcare Services Used by Adults with Developmental Disabilities in Ontario, so specific to Ontario. And it gives very good information about recommendations for how to support people who are facing issues and understanding. It's that awareness piece of why are people with developmental disabilities unique in their healthcare needs. The disparities come from various reasons, but just looking at these numbers, compared to general population, people with developmental disabilities are twice as likely to have a repeat visit in an emergency department within a month. There's 3 times higher prevalence of having the likelihood of having a repeat visit after being discharged, and their length of stays would be longer. A higher prevalence of having longer length of stays in hospitals. In terms of becoming alternate level of care, which means that the person has returned to their baseline and is able to now be discharged from hospital. Astounding, almost 7 times higher prevalence of becoming ALC. So not being able to transition at the point where they are well enough to come out of the hospital for many, many reasons. Some of them are that at the point that they access the hospital, they haven't had great preventative care. So they're accessing the hospital at the point where the problem has now become acute, and they've had a major change in the support needs that occurred before. 17.5 times as likely to need long-term care. And we're talking compared to general population. So it like 17 times as likely. So anyone who's from the long-term care sector, you will notice that there's a population coming to you that's new, and we've presented in long-term care facilities where people are saying that, we don't have anyone with developmental disabilities. This is not us. Isn't there somewhere else that those people can go? Seriously. So we really need to prepare, and this is part of us trying to go out and do outreach and prepare, that the population is aging and surviving and accessing community resources just like anyone else is. Unfortunately, premature mortality, four times higher. So why? Because the complexities are very unique and different. And so things that are not as prevalent in general population are more prevalent in the population of people with developmental disabilities. Seizures, epilepsy, issues with dental care, really basic issues, accessing dental care. And if you think about the piece of complex behaviors and having dental care, how that overlaps. If you're not able to tolerate someone going into your mouth and doing really invasive care, you're not going to get the care unless there are modified ways of getting that care. So for example, having behavioral support strategies, having desensitization, those are major things we want to try to do early on, and also prevent trauma in that the person's first interaction with dental is very traumatic. Then the person's not going to go back. So multiple things. The top 3 killers for people with DD are very different from the general population. Does anyone know the top 3 for general population? Heart, stroke, and cancer. For developmental disabilities, aspiration, so respiratory, blockages, constipation, and cardiac related to 3 to 5 times the amount of neuroleptic medications. So congenital, as well as having a lot of medications that the side effect is cardiac. So very different, unique needs. Any questions so far? So we touched on that 17 times the likelihood to need to access long-term care. We have from HCARD, there's a lot of research that shows, Ontario-specific research that shows that the population has doubled. So people are aging, they're living better quality of life in the community. So they're aging, and whereas mortality used to be at the age of 30 or 40, back in the 60s and 70s in the institutions, now people are living, and they'll be accessing long-term care. So it's again us getting ready to be able to support people going to places like long-term care, and also reliving that facilities type history, and people in long-term care being aware of that history and the type of approach to support someone with developmental disabilities. So yeah, I think we'll talk about how that overlaps in terms of behavior with health.
Okay, so I guess I'm gonna talk a bit more about manifestations of different kinds of behaviors, possibly related to healthcare issues. And so some of the things we've been seeing on our team that people talk about, but now we're actually seeing a lot of these things happening pretty frequently out in the field. So just some basic information there. So people with DD have a wide range of ways to communicate. So some of the folks we work with don't have any verbal language skills. Many of them do, and many of them are very good at communicating verbally. One thing to take into consideration is how we approach someone with a DD. Are we approaching them and communicating with them in a way that they understand us? That's always a very important consideration when you're trying to gather information. Again, as Angie was kind of alluding to earlier, there may be underlying health problems or physical issues or an illness or pain a lot of the time, and there's a lot of ways to kind of assess that. There's nonverbal pain scales where some data can be collected around whether or not the person is likely to be experiencing pain that certain behaviors could be related to. And I just want to ask everyone, because I like to ask this question when we do presentations, how many people have heard about applied behavior analysis? Oh yes, great. I'll share an experience. Angie and I were doing a presentation in a nursing home, and I asked the question, and nobody put up their hand, and I almost freaked out then and there. And it was in a long-term care home, and it was just really surprising to me. So that's a good chunk of this room. So in applied behavior analysis, we focus on the environment. We're not really looking so much as at internal causes of behavior. We're looking at kind of the environment and arranging that environment based on the person's needs. Okay, so this is a sort of like I guess a flow chart. It's from the DD primary care tool that Surrey has put out in the last few years, right, Angie? Yeah. So this is kind of like a flow chart that kind of gives you sort of a pathway to follow to determine what you need to do if you're seeing challenging behavior from somebody. Examples, like we see a lot of things like, well, I don't know if you see it a lot, but like self-injurious behavior. So if there's some kind of like pain going on with the person and someone is hitting themselves in the mouth, let's say, like that, as opposed to kind of saying, well, that's the problem behavior, we need to do something about that right now. In ABA, we would seek to kind of rule out those physical causes first to see if that pain is kind of facilitating some of that. And then maybe the person is, when I talk about environment and what impact the environment has on that behavior, maybe this kind of self-injurious behavior is resulting in pain medication being given to the person. So, and then pain kind of going away. So we have to look at it sort of from those points of view and explore those kind of physical aspects of the behavior before we move on to looking at other ways to address it. A lot of the time, if you look at underwear, medical condition is, has the red box around it, problems with supports and expectations. That is often the area, I think, where we're looking to focus a lot of time in our work. The environments may not be set up in a way that works for the person that's being supported. It might be too crowded. The way instructions are being delivered. I think Scott was talking a bit about this in his presentation as well. The expectations may be unrealistic for the person. as well, so we may just want to make some minor tweaks in that environment. And then of course, if there are emotional issues or psychiatric issues, then that should be addressed with the appropriate clinician. So, you know, if there's a suspicion of a psychiatric disorder, then the person should probably be seen by a psychiatrist in order to determine if that's actually what is happening. Another interesting thing I think to share, there's a recent study that came out from CAMH, it was Yona Lensky, I believe, and it looked at psychiatric or psychotropic medication prescription for people with DD, and apparently, based on, I forget how big the sample was, I think it was like 51,000, it was a big sample. Approximately 1/3 of people with DD have been prescribed psychotropic medication despite not having any kind of psychiatric illness or mental illness, which is kind of concerning. It kind of shows you that some of these other pieces around environmental sort of issues may not be addressed adequately, and then they're going right to the medication. All right, so I mean, this, for anyone else that's kind of an ABA person, this is a very basic kind of look at some of the strategies we may try. So we were talking about kind of different kinds of communication strategies, ways in which we can cue people as to what they can do. Visuals are something we will often implement right off the bat, just to see if that can get someone into a mode that's a little bit safer if they are engaging in problem behavior. One of the things that we've seen, I've seen in this role, is one of the really concerning behaviors are, for the people that do have a psychiatric diagnosis, is medication compliance. And so you do start to notice when medication compliance is up, is low, we start to see behavioral concerns emerge. So just something like this example here, like you see on the screen, trying to implement visual cues so the person remembers to take their medication. Let's see here. Okay, this crisis tool is also from the primary care tool that Surrey Place put out, and it kind of shows a continuum of what might be happening with somebody during a behavioral escalation. So this kind of tool can be used, and it's often used in behavior support plans for people in various environments, like group homes or hospital settings, or we even put them in place in long-term care homes. Just sort of when the person is doing this, staff or whoever is kind of supporting that individual respond in a certain way. Ideally, this will be based off of like a functional assessment of the person's behavior, and I'll talk a bit about that in a second. Okay, so I used the word functional assessment. How many people have ever heard of the term functional assessment? Okay, awesome, great. Okay, so everyone talks about functional assessment when it comes to behavior. It's kind of what needs to happen before recommendations are made. Because the most effective recommendations and interventions are based off of a good understanding of what the function or purpose of a specific behavior is. Behavior results in a good outcome. It'll strengthen motivation in that individual to access that outcome again in the future, more than likely. So a lot of people kind of understand that as a way the person with behavior is communicating something. So we're basically trying to figure out what that person is communicating. So I won't get into the whole, what are the different kinds of behavioral functions, and that's not what this presentation is about. So, and that'll take a while, so I'll just move on from there. Every good presentation involving ABA should have graphs. So here's some graphs. I'll try to explain these. So what this slide is getting at really is that the way in which behavior analysts will try to figure out why somebody may be engaging in unsafe behavior that needs to be changed is to examine it experimentally. Now, I won't get into the details, but there's ways to kind of assess that may be a little bit more different than some of the more descriptive approaches people have taken historically. So when I talk about ABC charting or ABC data collection, does everyone kind of understand what I'm talking about? I'm seeing a lot of nods. Yeah, so that's a very valuable way of collecting information about behavior. It tends to give you correlations, so it doesn't necessarily give you cause of behavior. But one thing that we've been doing in our program is I've been going in there and doing different kinds of these more experimental analyses to try to see if we can get to that root cause of problem behavior a little bit quicker and implement some strategies to try to help people out. I just wanted to make one more comment. Like, I wanted to maybe use one quick case example. How are we doing for time? Okay, yeah. So we've been talking about these different environments, and we've been hearing about places like long-term care homes. So I want to kind of just kind of give you guys an idea about the process. So one way in which kind of like our model can be used is to kind of first gather some information, figure out the function of the behavior, and then come up with like a very basic strategy that often can pay off. So one example, Angie knows this case very well. The person was using the emergency services several times a month. So in the month, over 30 times they had called 911, and there were no medical concerns, right, from what I remember? Yeah. And the person ended up going into a convalescent care program, which was not it's not the ideal environment, but we were able to kind of get her in a spot where we could actually implement some strategies with her. So we went from 30 times a month, the person is calling 911, and then ending up actually in Emerge 27 times, I think was the number, out of those 30 calls. And after we kind of put some very basic things in place and had her in a more stable environment, she was able to call the next day. How long has it been now? Several months, right? I think she's called 911 once, but hasn't gone to the ER. And so we were able to quickly figure out that a lot of this was based on accessing attention from other people and kind of seeking out comfort. So all we did was we kind of put attention from staff on a bit of a schedule. So they would proactively give her some attention, have conversations with her. And the other thing we noticed with her was we picked up on her skill set. So when we were actually signing service agreements, the person was very keen to look over every single page and kind of make sure she knew exactly what she was signing. So there's actually a behavioral strategy called contingency contracting. And it played kind of to her advantage, that skill, where we just kind of, we said, okay, we're gonna do a contract. This is how you're gonna ask for attention, and this is what we're gonna do, and part of the deal is we're not calling 911. And it was amazing how well it worked. I wasn't anticipating, because it's so basic, but that's kind of the power of figuring out the function of a behavior. There's also there's a couple of website links here that I think are very useful to check out through Behavioral Supports Ontario, also known as BSO. I had no idea what that meant when I first started this role, and then Angie educated me on that very quickly. But there is actually the healthcare sector, some resources available that staff can check out. And as we've been going into these other settings, we have noticed that people are accessing those websites. They know about the BSO website, and they're looking up those tools at the very least. So I think that is going in a good direction. That kind of, there's not a lot of behavioral supports in the healthcare sector and in some of the environments in which we're partnering with, but it's good. I think we're kind of getting closer to what we'd like to see. Yeah.
And we do have very similar approaches. So BSO and what we do in developmental services, the approach is quite similar in the sense that it's a gentle, persuasive approach. It's using, figuring out what is the underlying behavior, ruling out the medical piece first so that that doesn't get overshadowed by the behaviors. So just knowing that that understanding is actually there. And maybe it's done with different populations. It may be more of a geriatric population that knowledge is unique to, but it can be used very similarly in other support strategies.
Yeah, a lot of it's about language too. It's interesting. So for that contingency contracting thing I was talking about, those behavior contracts we were doing with that person, if I had gone in there and said to the team and to that individual, we're going to do this differential reinforcement of alternative behavior procedure and embed it within a contingency contract, you probably would not be too open to that. But if you frame it in a way, say, hey, I noticed you really like to do contracts, let's do one of those. And you kind of will have a lot of control over it. It's about you. It tends to work a little bit better when you frame things in a more relatable manner. And I don't know how other behavior analysts feel about it, but we have to kind of move in that direction in our profession where we're kind of making that jargon less of a thing. It's okay for our conferences, but not so much when you're going into like a clinical meeting type thing, or you're trying to help somebody out in the community. Yeah.
Maybe just add one more little piece. But for communication, as Aamir is saying, the communication piece is really the key that crosses all of us, all of our roles and sectors, right? And it's finding what is the right key to communicating with that person. And how that's done, just to ensure that we all know that it's very similar to how we do it in long-term care versus using behavioral strategies.
There's a question up there.
Can you stand up and speak as loudly as you can, because the cord will...
Sure, you want me to speak? Can you hear me?
Yeah, we can hear you.
Just a comment, when you stated you went to, I guess it was a nursing home, you asked about applied behavior analysis.
Yes.
Self-disclosure, I would have been one of those workers who would not have known what you were talking about.
Okay.
And as it went on, and the other lady spoke about be a gentle, persuasive approach. It's very similar from what I'm understanding, and that's the approach that we implement in our long-term care, along with other strategies. And I really appreciate your last comment about communication. The same as we now kind of have more understanding of where you're coming from and can see where that can impact us in our work that we're doing in long-term care. And we are seeing a lot more people coming in with developmental disabilities. So this is a very important conversation that we're having.
Thank you.
Thank you so much. Yeah.
Hello, we have a question over here.
Hi, my name is Mary Kate from Toronto Public Health in the Healthy Babies, Healthy Children program. Is there a difference between IBI and ABA, and if there is, like, what are they? Because I get really confused.
Sure, I didn't think I'd get any of these kinds of questions today. And I've never been, full disclosure, an IBI therapist. I've never been an IBI, but from my understanding, IBI is sort of a very, very specific kind of skills-based, as well as sort of behavioral assessment model for younger kids that's typically used with younger kids. And it usually involves more intensity, hence kind of the term intensive behavioral intervention. And it generally involves a lot of oversight from trained clinicians, although we don't really have very good rules here in Ontario about that, but I won't speak on that because this isn't a political discussion. And so it's, yeah, so you could think of it in a very crude manner as a more intensive, specific, although all behavioral interventions should be specific, kind of method of applying ABA. So ABA, if you think about it, is more the guiding principles and working within those principles, and IBI is a specific, intensive way of working within those principles.
I have another question. So,
Sure.
Children in IBI, are they also taking part in like speech therapy or occupational therapy, or is all embedded in IBI?
Oh, that's a good question. It wouldn't be kind of, because the behavior analysts are supposed to practice within the scope of their kind of knowledge. So behavior analysts, with some people, very few that are trained as speech and language pathologists as well as OTs. So those services, if the child is receiving them, they'd probably be getting them separately outside of IBI. If I'm butchering any of this, my BCBA colleagues, please let me know, correct me after the presentation.
If we have a written question, and if anybody else has any written questions, just wave them, wave your little blue sheet, and our student Johan will come by and pick them up. So our question is, can you discuss types of outreach activities that are taking place to help identify developmental disabilities among newcomers to Canada? So this is rather than having newcomers have to reach out themselves for support and figure out how to reach out for support.
So I'm looking at Director for Adult Work.
Hang on a second. Are you saying something the audience should be
Well,
answering
I'm
this?
just, that's.
Use the mic.
Oh yeah, sorry. That's a great question. I think it might be a question for DSO, the later segment of the day, in terms of outreach. For our team, we get the referrals through DSO. So,
I can add a little bit.
Hang on, let me give you a mic. I want to make sure it ends up,
So, Okay, I'm Jeannie Scantlebury, and I've just been ousted by my staff. I'm the director of adult program at Surrey Place, and as far as doing outreach, is the Developmental Services Ontario, and Karen White is coming this afternoon to speak about the program. They do a lot of outreach, they do a lot of engagements in the community. They present on their program and the kind of benefits of being identified and being registered with DSO. Because in Ontario, in order to access these kind of services, you have to be eligible for the DSO, right? So that's how we get our referrals. But the Developmental Disabilities Ontario, they themselves as the kind of the program that seeks to make people eligible and to kind of help them get onto different service lists and to help them get additional funding. They're the ones who are doing a lot of outreach. And currently we are engaged in homeless initiative and so doing a lot of assessments and screening at shelters, and it's quite amazing because about 1/3 of those people we are screening, they are also being identified as having developmental disabilities.
And for our team, we also do outreach with the healthcare sector. So we work with the LINs. We work in hospitals. We've gone out and done presentations with hospitals. So the health sector is also, if there's any interaction of someone who's suspected of having developmental disabilities, then the health sector is also aware and is able to call.
We have a question right here.
I just wanted to add to the services that are available. As an outreach, I'm Subrata from Streets to Homes. I work for Bridges to Housing that does housing for, works with individuals with developmental disabilities. The last government funded a program called the Connecting the Dots, and this program goes into shelters all over the province to identify individuals with developmental disabilities, to develop a database, and we don't know where it will go from there, but we'll get the actual numbers of people living with developmental disabilities in the shelter sector.
Okay, we won't go that. I can't get this that high. So either shout or if you don't mind coming down here. My apologies. Just share resource.
Hello everyone, my name is Mari Lamkin. I'm a complex support coordinator with Angie and Aamir and Scott, presenters today. In terms of newcomer services and immigration services, I took an online training, which I'll share with the room, whoever's interested. It's through OKZ, so the Ontario Council of Agencies Serving Immigrants, and what they actually provided was a kind of accessibility education training for newcomers and immigration settlement services. And so that's something that I felt like I needed to enhance my scope in. And so it's a free training. I can share the information with Scott and he can send that out for anybody who's interested in just understanding as a newcomer, what do we need to understand in terms of legislation, what do we need to understand in terms of accessing resources, and then as well as that element of, having the DD or the developmental disability or the mental health piece as well. So whoever asked that question.
Sure.
So she's going to email it to me as well, and again, inundate me with your emails, and I'm happy to share any resources that I can. Do we have any other questions? Okay, here we go. We have 5 minutes left. I have a couple of, did you want to ask a question? Okay, so here we have another question.
I'm come from the organization. We serve the Korean-speaking, the young adults with autism. Does the city have a specific program or mandate to serving some ethic-oriented DD, like a community organization or like people with that situation?
Second. Hi, sorry, thank you. I think that might be a better question for Karen White this afternoon, who's the manager of the Developmental Services Ontario. It's a bigger question than what the Community Network of Specialized Care kind of deals with. And if you're not here, I'm more than happy to take that information to Karen and forward the information on to you.
Do we have any other verbal questions? Otherwise, I have a few written ones. Okay, we have about 3 minutes left. So this question is around developmental disabilities and then later on an association with dementia. So have there been any studies or research on individuals diagnosed with developmental disabilities earlier in life and then dementia in later life? And especially in terms of behaviors and how to approach?
Yes, so there have been, and there certainly is a connection and prevalence with dementia and DD, especially with specific syndromes. So for example, with Down syndrome, and the DD Primary Care website also has a lot of information. There's health watch tables, and for example, there's a Down syndrome health watch table, and it has a section that talks about the prevalence of dementia with that specific syndrome. So there is a lot of information connecting the prevalence of dementia. Is that answered, or do you need more specific information?
I think we're good.
Yeah.
Any other questions? This is the last one. Okay, so I'm going to read this other question here. Can you, any of our speakers this morning, can you suggest some resources available for people who cannot afford or do not have insurance coverage around psychiatric help when they're also dealing with a developmental disability?
Yeah, so psychiatric help is can be accessed through OHIP, the OHIP system, and we do have specific psychiatrists in the GTA. We're lucky to have a few that have that specialty of dual diagnosis. Surrey Place, the adult program, has psychiatrists, and it's accessed through OHIP, so a referral from a physician to medical services, and that the psychiatrists have that specialty knowledge of the dual diagnosis, developmental disability with mental health. There's also clinics, not within Surrey Place. There's a clinic at North York General, a clinic at Humber River that are specific to dual diagnosis. And there's also in the East at Centenary. So there are psychiatrists that know this population well, and their services are covered through OHIP.
Just a follow-up to that question. Is it coverage for healthcare? Because this question, is it the person doesn't have coverage?
Oh, are you asking if they don't have OHIP coverage?
Yes, so that's what, just a follow-up to that question.
Okay.
Asking to the person who did that question.
Oh, yeah, that's a really good question.
Because there are agencies that if new immigrant or refugee who doesn't have healthcare,
Yes.
there are specific clinics that you can go to, right? That I don't have it.
Yeah.
Did you want to answer that?
So
Well, just from my limited knowledge, there's the interim federal health program plan that if it's medically necessary care, including psychiatry, there can be coverage in that way. Does that answer it?
It's about the city.
So,
Toronto that cover you. You do not need a health card.
Yes.
To seek support.
Yeah, I thought the question was about specific dual diagnosis psychiatrists.
so if anyone is wondering about medical and healthcare supports for persons living in Toronto or in the GTA who are undocumented or unable to access OHIP at this time, last month we actually held an event about the realities of being undocumented in Toronto, and we do have some brochures about the clinics that are offered. So if you have any questions about that, again, send me an email and I'm happy to send that information out to you.
And the community health clinics like Region Parker, also they have certain days that you do not have.
I'm glad you brought that up. In addition, okay, so what you were saying is, I think, is that There are programs like through community health centers. You mentioned Parkdale, Queen West, CHC, Regent Park, clinics for people who are undocumented, I guess is the label. But just to say that our team, in context, in relevance to our team's work, just to again plug that we can partner with those clinics, with specific people with developmental disabilities who meet that criteria for our team to be involved in.
And coming back to that, probably that's the first step where the family can go to, because some cultural different.
That makes
They
sense.
do not understand, or they may not have had that service from wherever they came from. So having the first step is having a doctor and then referring to service they serve.
Yeah, that's a very good point.
So the comment was, so the first step is always finding a family healthcare professional, a doctor or a nurse practitioner. It can be done often through a community health clinic. And then through that clinic, through that physician linkage, you'll be able to get linked up to the developmental services sector. So what we're going to, or to psychiatric health, or other healthcare supports.